Hi, everyone, and welcome to the Population Health Collaborative Fall Meeting. I am Suzanne Lawson with Constellation Consulting, and we are the convener for the collaborative. Also here from Constellation Consulting is Krista Martinez, who will be assisting us today. The Population Health Collaborative is funded by the New Mexico Department of Health, Heart Disease, and Stroke Prevention Program. Please note that today's meeting is being recorded and attendees' cameras and microphones are activated. However, we do ask that you keep your microphones muted. If you need assistance during this session, please enter it into the general chat or message Krista directly, and we will be happy to help you. As we begin today, we will not be doing live introductions, but please feel free to enter your name, role, and organization into the chat to introduce yourselves. Following each of today's presentations, we will have time for Q&A, and you may ask your questions live or post your questions in the chat window. Also, if you would like to make sure you are added to the collaborative email list, please enter your email address in the chat window or email us directly at info@constellationnm.com. We are pleased to offer continuing education units for pharmacists, community health workers, and health education specialists for today's session. At the end of today's session, we will post a link to our session evaluation and CEU request. If you are attending today's session by phone only, please stay on the call at the end of the session so that we can confirm your contact information and CEU request. And before we move into today's scheduled presentations, PHC member Comagin would like a few moments to talk about free technical assistance that they are offering to support self-measured blood pressure programs. Please welcome Comagin's Alberta Davis.
My name is Alberta Davis. I'm an Associate Improvement Advisor here at Comagin Health. Thank you for giving me a moment to speak to you all today. I'm excited to hear the presenters, but I wanted to take a moment to address the technical assistance offering that we're promoting here at Comagin. Comagin Health's partnership with the New Mexico Department of Health Heart Disease and Stroke Prevention Program are now offering the opportunity to receive free technical assistance. High blood pressure, we know, is a contributing factor to major health conditions, including heart attack, heart failure, stroke, kidney failure, and many others. We're here to support your current work in SMBP to begin, continue, or to expand a self-measured blood pressure program as a tool to help more patients achieve blood pressure control. Next slide. Comagin Health can provide targeted technical assistance to support your SMBP program in several key areas, including patient identification, evaluating readiness, creating team workflows within an SMBP program, participant engagement and retention in self-measured blood pressure services, both virtual and or in person, quality improvement and implementation methodologies. We're partnering with Synchronous to provide EHR technical assistance in order to enrich the quality improvement work and focus. And we're also partnering with American Heart Association to ensure and promote collaborative resources. And we're hosting an upcoming webinar on November 29th. So if you're interested and have not been invited, please send me a chat. We're here to help you regardless of which stage you're at, and we'll work to bring value to allow you to serve your patients and improve outcomes. So really looking forward to meeting and working with you. I'll go ahead and drop the SurveyMonkey link to the technical assistance application into the chat. The survey takes less than 5 minutes to fill out, so please go and fill this out if you're interested. I'll also place my email address into the chat if you have any questions. Thank you so much for your time. Back to you, Suzanne.
Thanks, Bert. And now we are pleased to have Dr. Tesia Buszkiewicz, pharmacist for Duran Central Pharmacy. Dr. Buszkiewicz graduated from the University of New Mexico College of Pharmacy with her Doctor of Pharmacy. She has numerous certificates and licenses and is a member of the American Pharmacists Association, the New Mexico Pharmacists Association, and the National Pharmacists Association. You can read her complete bio at nmhealthequity.org/PHC. Please welcome Dr. Tesia Buszkiewicz.
Hello, everyone. Let me just get my slides up for today. Thank you so much for being here this afternoon. And I am currently working at Duran's Pharmacy right here in Old Town in Albuquerque. If you haven't been here, come check us out. It's the only place where you can get a flu shot and green chili all in the same building. And of course, we're all a little flu shot crazy this year if you're in community pharmacy with the COVID boosters as well. So we are a little different, a little unique. We're a pharmacy, a restaurant, and a gift shop. So it's a really great place to work. I was lucky enough to start here as a student, worked with them as an intern, and then when I graduated last year, I'd start with them as a pharmacist this year. So I've been involved in their MTM and various programs before I was licensed, and just kind of took the wheel, and I'm working with many programs at Duran's, including our diabetes prevention program and our heart disease and stroke prevention program, which really ties in closely to the blood pressure monitoring Alberta was speaking about, as well as our MTM program. So we utilize MTM in our heart disease and stroke prevention program. And I'll give you a quick moment to look over the learning objectives here. Really, we're focusing on MTM in a community pharmacy setting, specifically how it can relate to cardiovascular disease. So MTM, an abbreviation I've already used about 3 to 4 times, and you'll hear about 20 times today at least, is an abbreviation for medication therapy management. We know we love our abbreviations in pharmacy, and really it is an umbrella term for services to ensure the best therapeutic outcomes for patients. So this can be many different things. It can be ongoing medication management, looking at the entire medication regimen, and really looking for therapeutic effectiveness. It's our chance to look for potential adverse events that we can prevent, and really focusing in on individual patients' medication goals and therapy goals. So we may be looking for uncontrolled type 2 diabetes or uncontrolled high blood pressure. We're really providing education for our patients for how those medication therapies work and how they work best. And then additionally, we can look outside of the medications as part of the MTM process. We can look at those different lifestyle modifications, which could be beneficial for health outcomes. So there are the annual MTMs, which are offered through many of those star rating platforms. But it may be beneficial to have regular check-in with patients, regular reviews with patients. And interestingly enough, this is a statistic from the University of Michigan's poll on healthy aging. About 85% of these Medicare patients who were eligible for an annual MTM with a pharmacist didn't know they were eligible and never had one completed. So it's interesting that this is a service that's offered that many patients aren't yet aware of. This is a look at our specific MTM program here at Duran's. This is for all of our patients who fill chronic medications with us, not just the Medicare patients, but you'll notice that as part of our MTM platforms, we do look at those star rating measures. I'll dive into that a little bit on the next few slides, but this is an example here of what we'll be looking at in our community pharmacy when we're doing an MTM process. So we'll look at some of those star rating measures. We'll look for potential interactions and provide education and counseling. At Duran's, we always will do a natural product review and potentially look into beneficial supplements and over-the-counter items that may be beneficial for patients. And of course, we'll do a full immunization and screening. And this is an example of a document we have used in the past to complete these MTMs. So the star rating platforms, these are the big ones. These are hugely involved in current MTM and community pharmacy. So those are the sort of platforms like Equip, Outcomes, or Optum. They all have different star rating platforms. And really, these star rating platforms reward quality healthcare, not directly. We do get some reimbursement from the star rating platforms and we act on different tips and different things, but it's not nearly enough. Really, what's going on with these star ratings is the CMS will rate a provider, not a pharmacy. They'll rate a provider on a scale of 1 to 5 based on different performance measures, including pharmacy-related measures such as medication adherence. Then patients sometimes will look at these star ratings and they will use those star ratings to select their provider. So it's an indirect influence that the community pharmacists are having on these star ratings measures. It doesn't directly reward us, but it is something that we could be hugely valuable in, hugely instrumental in, because we can actually help influence up to 50% of these star rating measures that physicians are being analyzed on. And really, we are trying to improve these star ratings as it relates to medication therapies, not just to help the providers, but really to help our patients. There is certain areas such as high-risk medications, those diabetic pharmacotherapies, and those medication adherence pieces that are really, really closely tied to a STARS ratings for those plans. And it can really influence enrollment, and enrollment can increase with good STAR ratings. So speaking specifically about these Part D or the medication immunization ratings, it's looking closely at adherence for those chronic disease states, including diabetes, high blood pressure, and cholesterol. It's also looking for those high risk medications, such as those listed on the Beers criteria in the elderly. And of course, as of now, there are new immunization related metrics as well that they're looking for. So working with these star rating platforms, I and our students, our techs, everyone's really involved in the MTM process here at our pharmacy, but we will provide education related to chronic disease states, specifically for cardiovascular disease, but also for some other disease states. And really the research is out there showing that a community pharmacist involvement in MTM can be very effective for lowering blood pressure, cholesterol, and glucose markers. So we know we can have an impact. We know that we can be influential and provide good education to patients. But it's really a matter of figuring out how can we fit this into our workflow? What is going to be the reward if we're not getting much reimbursement from these star rating platforms? How is it going to be effectively implemented within a community pharmacy? So with our pharmacy, we'll usually start with a complete review of all the patient's medications, their immunization history as well. We're looking for things like non-adherence. We're looking at those fill-refill dates. We're really determining if they are using their medications appropriately or perhaps overusing or underusing those medications. Really looking at adherence for things like those blood pressure medications, statin medications. And really, it's our chance. I always view it as our opportunity to explore what may be going on with our patients. Sometimes when I'm doing these MTMs, we'll figure out that they are experiencing a side effect or an adverse effect from a medication that they weren't previously aware of. They didn't know it could be a side effect of their medication. They didn't know it was tied back to a drug. So it's really my chance to listen to my patients, listen to what's going on with their health, and then as a pharmacist, dive in, see if these are medication-induced side effects that could perhaps be prevented or avoided, or see if there's some serious adverse effects that we need to address. Additionally, we could recommend appropriate monitoring, such as that home blood pressure monitoring. We could look for those regular screenings being done, such as a cholesterol screening, asking our patients when the last time they had something like that done. And really, when patients have a better understanding of their medications, they're more empowered and they're more likely to be adherent to their medications. Additionally, we can provide that additional education as it relates to lifestyle. Really, I view my MTM as my chance to check in with my patient to make sure that I'm taking the best care of them as possible, to make sure that they're knowledgeable about their medication therapies and any lab or monitoring that we would recommend for them. As I mentioned at Duran's, we also look at the OTC and herbal products. I think that this is something that should be really included in MTM, but can be frequently missed. We know our patients are using over-the-counter items. We know they're using herbal products, but we don't know necessarily if they're using them safely and if they've considered potential interactions between the natural products they're using and their medications. So at Duran's, we'll include that in our MTM process, and we may even make recommendations for supplements or things that may be beneficial for those who take medications every day. Chronic medication use, we know as providers, can cause nutrient depletion, especially things like those heart medications, the diabetes medications. Those can deplete nutrients and vitamins over time. Maybe we should be looking at what could be depleted by our patients' medications and really recommending a good supplement to go along with them to help avoid what is, in my mind, a preventable side effect. We also may make recommendations for pain or sleep, really listening to our patients, figuring out what's going on with them, considering their medication regimens and what over-the-counter items could be recommended safely. So this is our process in a nutshell for the immunization piece of the MTM. Really, we will look at the state database, we'll look at NMSIS and the patient-reported vaccinations before we develop vaccination recommendations. Then we'll let our patients know which vaccines they may be eligible. This is huge. This is the time of year where really we can be doing more than just giving our patients their flu shots and their COVID boosters. As I mentioned, I know we're all a little overwhelmed with vaccines these days, but this is our opportunity to see if they could be due for something else. There's the new pneumonia vaccine. Are they perhaps eligible for that? Are they up to date on their shingles immunization? So I would encourage you, if you are considering developing an MTM program for your pharmacy or for your healthcare practice, think about an immunization component. This is a good opportunity to quickly get some revenue into your pharmacy. And truly, we know that we were on the front line of this pandemic. I'm so grateful that we were able to provide these COVID vaccines, because if we think about it in an antiquated way, if we were thinking, oh, only my primary care provider could have given me that vaccine 50 years ago, we know we would still be on first doses by now. So really, guys, we are now the front line for vaccinations. We're the most accessible provider for vaccinations. And this is a big opportunity for us. MTM can be a big opportunity for us to make sure that we're keeping our patients up to date on vaccinations, and we're bringing that revenue into our pharmacies. Patients really appreciate this service. They really appreciate someone checking in on their immunizations at least annually. So I highly recommend that as part of your MTM component. And really what we'll do for our pharmacy, this is kind of our standard workflow. We will utilize that form I showed you on the third slide to document any potential recommendations. If it's necessary, if we're noticing that we need to contact the provider right away before we speak to the patient, we will start that. We have some pre-generated provider letters that we will send out for things, including our MTM program and including those outcomes and STAR equip rating platforms. We have some pre-generated provider communications that we will use to send a letter to providers' offices. A common example is a statin omission in type 2 diabetes. We'll send those letters off all the time. And then we'll talk to the patients. We'll discuss those recommendations with them. We'll follow up with them as necessary. We'll follow up with the providers as necessary. And then we'll really document the outcome of their annual MTM on our patient profile. It is our goal for patients who fill meds with us chronically that we complete 1 MTM for them per year. And so I always tell patients, you know, at least once a year, we're going to be checking on your medications. We're going to be looking at your immunizations. We're going to ensure that we're taking the best care of you as possible. And I'm telling you guys, patients love this sort of service. They love this sort of feedback and education. For the most part, they're really appreciative to be a little bit more knowledgeable about potential interactions, to know if they're up to date on their immunizations. So really, it's a good opportunity for us. And tracking your MTMs is really important. Make sure you're tracking these sorts of recommendations and the responses. That way, if you do another MTM, that you have that information. It's really helpful moving forward to have this information documented on the patient profile and looking at it at least once a year. So we know a little bit. This is some information I had gotten from a study about how community pharmacists specifically can help with some of these medication therapy management interventions, and what are the sorts of benefits, specifically as it relates to cardiovascular disease. They have shown that community pharmacy involvement can help reduce hospitalizations and help patients live longer, healthier lives, and those with high blood pressure and other chronic conditions. Medication adherence greatly improves with pharmacist involvement, and patients are more satisfied with their care. This can lead to better outcomes, and this regular screening of patients for their disease state control and their medication adherence gives us more opportunities to check in and look for those potential adverse events or perhaps uncontrolled disease states. They may get to see me in the pharmacy once a month, and they may know their blood pressure is high at home, but they may not see their doctor for another 6 months. So we know that we can really be an accessible provider in the community, that patients will appreciate pharmacist involvement. And working with these sorts of programs, I have seen things like blood pressure numbers, cholesterol numbers, and A1C numbers go down just with pharmacist involvement, specifically managing their medication therapies and having these sorts of regular check-ins with patients, if not at least an annual MTM. But it's not just pharmacists. Really, as I mentioned before, this is a team. We love our interns. We love our technicians. The technicians are who sees my patient at the window every month. They are the person that interacts with the patient face to face. So your technicians may be more liable or more readily able to identify those potential opportunities for MTMs. They know if the patient refuses their blood pressure medication at the window every month. So our technicians are extremely valuable and have to be included in the MTM process. You want to make sure that you have technicians not only trained on MTM, but with a good knowledge and understanding of what those clinical pharmacists will be working for. It's beneficial mutually for us. We love our techs, and our techs actually love being involved in this. I found a study that said that technicians were more satisfied with their work when they got to kind of work with this clinical service. So of course, they cannot directly counsel patients, but they may be able to allow the pharmacist to spend more time on those sort of clinical aspects. They may be more aware of that patient and how they use their medication so that they can better assist us in developing those patient goals. And if we use our technicians, we're going to have a higher MTM completion rate. So we want to make sure that we have pharmacy technicians involved, pharmacist involvement. It's so important that we get the technicians on board prior to implementing MTM in a pharmacy. So I will open it up for questions.
Thanks so much, Dr. Buszkiewicz. We do have a few minutes for Q&A right now. If anybody has any immediate questions, otherwise we will hold Q&A for both of our presenters at the end. So if you have any questions, just real quick, you can go ahead and put it in the chat, or you can bring yourself off mute and ask. I think one quick question I had actually goes back to the beginning of your presentation, where you were talking about patients not knowing that this was an option for them. And so how can we in the community or pharmacists or pharmacies help increase awareness of this?
Well, it is that time of year where I am doing a ton of patient calls regarding these Medicare funded MTMs and the outcomes platform. Patients do receive letters in the mail notifying them they are eligible of this service. But I'm doing a lot of cold calling, and I think it's just become this phenomenon these days where no one answers calls, even from a known number such as your pharmacy. Even when I leave a voicemail, I'm never quite sure if my patient listened to the entire voicemail. So I am not sure of the best means to make this information available to patients. Perhaps it's their provider being more readily available and letting them know, hey, have you done your annual medication review with your pharmacist? Maybe we need more information coming from providers regarding these medication reviews, because it's coming from the pharmacy and it's coming from the plans, the providers, as far as the health insurance plans. But I'd love to have more physician involvement, more team-based care, and more physician referrals for MTM. I think would be really beneficial moving forward in the future.
Fantastic, thank you. I think we have time for maybe for 2 more questions, and then the other ones that are coming in we'll hold for the very end of our session today. So one question is, are you getting reimbursed by CMS for pharmacist MTM?
Through those specific platforms I had mentioned, the star rating platforms, they do reimburse you for completing the MTM and submitting that information to the health plan.
Okay. And then we have a question about, do you put notes in the pharmacy bag?
Bag stuffers. No, we have not implemented bag stuffers for our MTM program. Our pharmacy is a little different in that we have our patients on a synchronization program that will line them up for the medication pickup every month. So those patients, regardless of if we get a paid MTM claim through the star rating platforms, we complete an MTM for them once a year. And rather than doing a bag stuffer, which is handed to the patient, we have that documentation I had showed you guys with their medications. And that's how we'll try to catch them. If we don't get them on the phone, we'll try to catch them at the window and check off a couple MTM boxes while they're there. But I think bag stuffers in community pharmacies, if you're having trouble reaching patients, letting them know they're eligible for an MTM is a great idea if it's not a program you have in place already.
Okay, thank you. So I know we have a few more questions that came in, but again, we'll hold those until the end Q&A after our next presentation. So thanks so much, Dr. Buszkiewicz. We really appreciate it. And she will be hanging on for the end Q&A as well. So now we are pleased to welcome Dr. Amy Bachyrycz, a pharmacist at Walgreens Patient Care Center. Dr. Bachyrycz received her Doctor of Pharmacy from the University of Connecticut at Storrs, magna cum laude, and her postdoctoral in general pharmacy practice residency at the American Society of Health Systems and New Mexico Veterans Affairs Healthcare Systems Hospital. Dr. Bachyrycz has several professional licensures and experience in certifications and experiential trainings, along with numerous peer review publications. Again, you can read her complete bio at nmhealthequity.org/BHC. Please welcome Dr. Amy Bachyrycz.
Thank you, and hello, everyone.
Hello.
All right, great. So thank you for that lovely presentation. And I think it complements mine because I don't have any of the same slides that you'll just see, which is great, because I work in a busy chain pharmacy. And so my MTM is probably not as thorough, although I would love to have as much time with each patient. I do have to do what fits best into workflow. for me. And so I love helping patients, love doing MTM, but I don't work in an independent pharmacy. So it might be a little bit different. And what I would say, what would work best is to take Dr. Buszkiewicz's presentation and mine, and then modify it to combine into one MTM program that best fits your needs. Because she had some great things on there. The follow-up, I don't really do that. And that's kind of important. So I'm not great at follow-up with patients and then documenting this was a successful intervention, this wasn't. And so I'm going to try to implement more of that. And so, yes, you had some really great things that I liked. So I'll probably be adding to my MTM program. So I would encourage you to take what works from both of our different MTM experiences. So just a description. Basically, I was going to use a patient case, but I just wanted to go through MTM as quick as possible because we're kind of short on time. And I only have 20 minutes. So I don't know if I'll be able to go through a specific patient example, but if I can, I'll drag you through a patient case and you can see how I work my MTM in a busy pharmacy. So these are my objectives. We're going to go through the benefits and needs, which most of you already know, and then define and understand an implementation of the MTM program, the measurable outcomes, and then lastly, review the barriers and benefits. So we have some really great benefits of the MTM program in a community pharmacy that that Duran's maybe doesn't touch on or didn't touch on. I really like your herbal and natural or non-pharmacologic stance. Also, I've been using a lot of leveraging community resources. So maybe that's something, Tesia, that you can add, because a lot of times patients will complain about they don't have enough money for electricity. And so I might use a community resource to get, you know, PNM help or something like that. So we have some community resources in our state that a patient could benefit from, not related to pharmacy. And I can use some of those, that knowledge of advocacy and embed it into MTM, which is what I like to do as well. So in order to get all the team members involved, meaning the technicians, my front end, everybody involved in why we should do MTM, yes, I have to tell them the return on investment, but I also have to teach them the patient benefit, the why to being proactive about MTM. If they don't see me wanting to do it, they're not going to offer it to patients. If they see me saying, oh, I don't want to do any flu shots today, they're not going to tell patients we offer flu shots at this pharmacy. I can tell you right now. So the motivation from the other team members is stemming from you, the individual pharmacist. If they see it be a burden, you're sighing every time you have to go and sit with the patient, they see you rolling your eyes, then there's no team member that's going to want to give you more work that you don't want to do. So they have to see me offering it, hear me on the phone talking about it, telling them about the program and all the amazing things that I've done for people through it, so that they understand the why behind it, not just in a textbook, me lecturing at them sort of way. They have to like feel the passion for MTM and adherence. And I teach students, and I'm trying to teach them, it's not just about, you know, taking your pills every day. It's about having your heart work not as hard and being around for 5 or 10 years longer. So really understanding the why behind it, to get all those team members on board, to then want to advertise your MTM program or your ability to make this great intervention. So don't feel like you just have to have them sign a paper, you know that we can do MTM, and they check a box. They really have to see you excited about it. And so why do we do it? Obviously, this is the most common medical intervention. Changes in prescriptions, manufacturers. I saw one of the questions in the chat. Do you do MTM every time there's a change in dosage or every time there's a discontinuation? Unfortunately, no, I don't have the time to do that. But when I do identify a decrease in adherence, I look for if there's a discontinuation or a change in dosage, so that I'm not asking a patient something that I can figure out from a medication profile. So like I look for a dosage change, And that's my reason why they're not adherent. Instead of asking them, why are you not taking your, risperidone? Oh, they DC'd that medication and switched you to another antipsychotic instead. So I don't ever want to ask questions without doing the little bit of research. Just like when Tesia was talking about cold calling, I'm pretty sure she does her research to see before she cold calls and asks someone, have you ever been on a statin? Well, yeah, they were prescribed the statin, they just stopped picking it up, so that you don't call and then ask a question that you can deter from the patient's medication profile that you have in front of you. And that's not just MTM, that's with any type of questions for patients, because you can look at a medication profile and put 2 and 2 together. And a lot of times, maybe a cold call, it might have changed what that discussion was going to be like with a patient. So instead of faxing an omission for a statin, now it becomes an adherence call, right? Because they already have a statin on their profile. You're not going to reach out to a prescriber and say, patient's never given a statin, because they clearly have an on-hold prescription for a statin. So I've done that enough times to feel silly. So now I know not to do that, because it is very embarrassing. And then lastly, ensuring patients get the most benefit. So I explained and showed my technicians, why do we need to manage medication therapies? But now it's the patient's turn. Why do they need to be empowered? So they need to know what the long-term benefits of these medicines are, what are their medication goals, and then also what are their disease state goals? Because I can tell someone take a blood pressure at home all day long, but if they don't know what numbers they are supposed to be getting, they'll come back and report, oh yeah, isn't this good? But they're not at their goals for that specific disease state. So that's really important to me too. So the needs of the MTM, obviously there's money involved. So we want to decrease hospitalizations. We want to keep them out of the hospital. We don't want any frequent flyers. And then also I want them to reach their disease state goals and have the best possible health outcomes. I don't want them to burden the healthcare system. If they have, and we already just heard about this, but if they have a reason why they're not taking that statin, I can help solve that problem, but I can't solve a problem that I don't know what it is. So the first thing with adherence is I need them to admit the reason. Is it transportation? Is it that they don't believe in the medication? Are they on too many medications? So I know many of you said, well, motivational interviewing, I'm not going to use that. This is our time to shine. All the motivational interviewing that you learned in school, we have to convince patients to tell us the reason why they're not taking the medication. And then we have to convince them to now be adherent with that medication, just like a vaccine, right? They don't want to get a COVID shot. It's my job to educate them. And I'm not twisting their arm. I'm just using the knowledge that I have and being their advocate and motivationally interviewing them to consider getting the vaccine, consider taking their statin. I'm not good at salesmanship, I can tell you right now. So I struggle with this. I had a patient, and once it gets kind of heated, the argument or the conversation, I usually just like end it real quick, but I need to be better at saying, okay, so you're not sure about the vaccine, or you're not sure about taking your statin, instead of saying, well, we can talk about it at the next visit, or let's discuss it more with your provider. Why don't I close or end the conversation with saying, we'll take it for now, and then we'll see how you do, and I'll check in a few days. Get the vaccine now, and I'll give you any new information down the road. But usually I kind of get cold feet with the conflict, and I'm like, well, I'll be here until 4 o'clock. If you change your mind, come back and get the vaccine. So we need to use our motivational interviewing to have the patient admit what the non-adherence problem is in order to fix it. So anyways, let's go to the next slide. We have appropriate patients. So outcomes obviously is one way to identify MTM patients. So outcomes will tell me who I can get reimbursement when I call them and I look at their medicines. but I want to help all patients, not just the ones that outcomes tells me is eligible for MTM. So these are other patients with gaps in care. And maybe I won't get reimbursement for the service of MTM, but I can get reimbursement through grants. I can get reimbursement because now my pharmacy is going to have better adherence rates, or my patients who have high cholesterol or diabetes are going to be on statins or have great immunization rates. So there's other patients other than outcomes patients that need MTM. In my opinion, everyone needs MTM. Even if you're on no medications, you'd still benefit from over-the-counter therapies, vaccine workups like we were discussing before. So everybody needs MTM, diet and exercise consults. So there's not one patient that wouldn't benefit, even if they're the healthiest patient of all. So these are just some patients that you could identify. Let's say you wanted to focus on patients that had a lack of a medical home. I know we have some people that really look at diversity here on the call today, or maybe we have patients that are in a complex disease clinic. Some of you are in a federal clinic, so you may have some chronic diseases. So maybe you're running a chronic disease clinic. So those are all patients that would benefit from individualized MTM. And you can have a couple of focuses, and I'll talk about that in a little bit. So the attempt to get as much patient history from a patient as possible is how I need to work, because I'm in a community pharmacy. I'm not going to readily have a lot of objective data. I don't have the lab values right in front of me or an electronic health record, unfortunately. I have everything they'll tell me, which is great, and I will take it all down. And then also whatever technology I can leverage. If they have my chart, if I have any type of objective data, and then what I can get objectively. If I can take vitals, obviously I can do blood pressure, I can do oxygen saturations, I can do body mass index, all of those things. Whatever I can take objectively is great and will be more helpful. I have the refill dates, their adherence, I can deter that from their medication profiles. So all that is excellent. The more I have ahead of time, the easier it is when I go in to do the MTM to see it all laid out. So the ineligible patients, these are the ones that generally I wouldn't look for because they're already included in an MTM program, outcomes, or they have a third-party payer that hires their own pharmacy to do MTM. Maybe a patient that can't speak the same language and I don't have a translator, or if they're unwilling to participate. So those are the patients that I would generally exclude, not because I want to, but because I want to do as many patients with the resources that I have at my fingertips. So if I'm familiar with the patient's health status and their health goals, and this isn't something that I need to spend gobs and gobs of time on. This is just something that I can quickly look at their profile 5 minutes before they come in, and using my own knowledge and then also their goals, I can kind of figure out what's the best action plan. I don't spend a lot of time on it because in sitting with a patient, it's going to change and it's going to be individualized. So I won't spend too much time on the pre-workup. If you do that, sometimes a patient won't even want to participate in MTM. So I don't always spend a lot of time on the pre-work because oftentimes it's not successful. Okay, so the more you know about the history, the more concise your MTM plan can be. And let's just say we're going to do the American College of Cardiology and American Heart Guidelines. I have a patient that we're going to say the target blood pressure of less than 130/80 is recommended for adults. So that's what I'm going to go with. Now, let's say pharmacy X over there wants to use 120/80. That's their goal, and they're going to have everyone stick to that. That's okay. Every different pharmacy can go with what they want, but the most important thing is that we're all consistent within that one pharmacy. The reason why I'm choosing 130/80 is for my patient population. This is a more realistic goal. And as long as I have a guideline to back that up, would I love for everybody to have a perfect 120/80 blood pressure? Absolutely, yes. So for this guy, they have a 10-year atherosclerotic CVD risk of 10% or more. And then the next bullet's a target of less than 130/80. And that's reasonable if they have no additional risk factors. So we'll go to the next slide. And what I back that up by, and I make sure that all the pharmacists know the charts that I'm getting this from. And we do this with vaccines as well. A simple chart on the wall. I don't want a 2-pager or a 3-pager. I just want something they can see so everybody's on the same page. So we don't all throw different numbers at a patient if I'm not there or if they get a different call. The most important thing, vital, is ease, easy to find, and consistency. That's at least for my pharmacy. And obviously correctness, which I didn't think I had to put here because that's, a given. So this is what we would go with for our patients right now. Does it change? Yes. Does it need to be updated? Absolutely. But in a busy community pharmacy, just like with vaccines, I need to have a chart. What am I diluting my Pfizers with, right? When they need to be diluted. It can't vary. It has to be the same for every single patient. And so it's really important to have a chart and that everybody's on board with that chart. Next, gathering the info. And like I said, subjectively, I got all that info from the patient, but objectively, there's databases. So even if you're at a community pharmacy, you can look for some objective information before a patient comes in. So for instance, I have, and this is for those of us that don't have an electronic health record. What I'm doing is I'm leveraging the databases that are available. I think we already talked about NIMSIS, which is the immunization database there. Super easy to get a sign on. It's free and it's available to everyone giving shots. And it's great because patients say, I want to have my state database updated and up to date. So it's a really nice way where I can convince them to get vaccinated and I don't have to pull out my big motivational interviewing skills. And I can say, well, the state database says you're missing your shingles vaccine, Mr. Smith, who's 50 and above. And so now Mr. Smith says, oh, well, I want the state to know that I'm vaccinated for shingles. And there you go. I've just sold Mr. Smith a shingles vaccine. And so, of course, there's return on investment, but also it's good for his health, right? Because we know that shingles vaccine, a 2-shot series, is super effective. Also, we can look at medication profiles. So I will look at all of the community chain pharmacies that his meds could be at, not just my own. Also, the prescription monitoring program, if he's on controlled substances, I have my sign on for that and that's free. If there's, like I said, my chart or some other, technology where I can see his labs and he gives me access to that, that's great. And then, any other type of, there's NIM-HICS, which actually does cost money, but that's the state laboratory values. I believe it's $150 per provider. So if you wanted to sign on to that, we do have a state database for labs. So the appointment overview. So I review Mr. Smith's chart. He's 50 and above. He's got a little bit of high blood pressure. I look at his meds, look for adherence and refill history. We talked about that already. Look at his New Mexico state database for vaccines. My appointment time is always going to vary. It's probably not going to be as long as I'd like because I do have lots of other patients waiting in a busy community pharmacy, but it's going to be, at least, 10 minutes, generally speaking. And I let everyone know in the pharmacy, I'm going to go do this MTM appointment, tell everyone, bump up the wait time by 10 minutes to everyone so that everybody's on board. They know I'm doing it. They know I like to do it and everybody's all on the same page. I take his vitals if I haven't been able to do that already, or I have an intern take them, kind of leveraging the team members that I have available. Also, then I go through his medicines and make sure that there's no issues or concerns. And this is exactly what seems like Duran's is doing. So she dives in, I think was the term that she used, and she listened to any problems that he had. That's really important because if a patient says, I don't think this med's doing anything for me, then clearly we need to identify what, those feelings are, what the med is, what can we do to fix that. Community pharmacist has changes. And so we oftentimes have a lot of turnover or different people in the pharmacy. So we have to be ready If somebody needs me to move that appointment with Mr. Smith over to the next room, I'll do that. If they need me to move to an aisle, if that's what I have to do to give Mr. Smith the time that I need, heck, I'll even do that. So I have to be willing to adapt in a busy community pharmacy because not everything gets uninterrupted. Okay, so now I'm reviewing each med and I'm going to modify my 3' questions. You guys remember this from pharmacy school. We ask, what are you taking the med for? How are you taking the med? And what concerns are you having? This patient's been on the medication, right? This is not a new medication. So now we can modify them to meet the needs that this medication has for, that this patient has for a specific medication. So if it's his lisinopril, what are you taking the med for? Let's make sure he still knows. And how have you been taking this medicine? Once a day? Okay, good. That's still, as prescribed, to make sure that he's concurrent with dosage changes that may have occurred. So what concerns have you been having with this medication? So the same type of thing, some slight modifications, but let's bring back those 3' questions. When we train students in the lab, the 3' questions, we let them know that all of you out there in pharmacy have been trained to do this, okay? If they're working for you or with you and you don't do it, I specifically let them know that is your own abbreviation to counseling that you've made because you felt like your counseling techniques were more effective. But these are universal prime questions to pharmacy. Okay, so next we have our assessment. Now I'm going to review each medication that Mr. Smith has to make sure that each of the meds he has an indication. And I remember doing this during residency. I would be looking at all the inpatient's meds and make sure a diagnosis was on file and vice versa. Because the minute you didn't was the minute your preceptor asked you, well, why is he on omeprazole? And so, yeah, that was, sorry, let me just get my charger. That was something that I remember doing during my residency. The next thing is also making sure it's an appropriate dose, that he's reaching his disease state goal and raised concerns. If you can have a templated soap note, and this is not like the 3-page soap note you might have had to turn in pharmacy school. This is like a very quick assessment and plan soap note that's templated. Usually my assessment will have a little paragraph. Mr. Smith is on lisinopril for his blood pressure. He is currently taking 10 milligrams every day, has been diagnosed with blood pressure for the past 10 years. He's taking 10 milligrams, or I already said 10 milligrams a day. His current goal is, and then I would say 130/80, and any raised concerns that he may have. That would be in my assessment, okay? So you can template it out and leave those things blank that you want the MTM interviewer to fill in. And then also for the plan, each disease state I usually list in order of priority, just like you did in school. So obviously hypertension would be one of your top plans. And then in a 1, 2, 3 format, just like we would do in our current outcomes MTM, if you're doing that, we would just put the points addressed. So lisinopril 10 milligrams, continue taking as prescribed if there's no concerns. If there were concerns, we would list it there. Blood pressure, continue monitoring at home, consider a blood pressure at home journal. And again, this can be templated out as well, but please have a few 3, 4, and 5 blanks for Mr. Smith's individualized plan. For instance, 20 minutes of exercise a day or something like that. So the more I can template out, the more consistent, but then more individualized I can make his action plan. Because I don't want to spend time typing a lot of words that I feel like could already be typed in my assessment and plan. So here's our sample. Review each active medicine, modify your 3' questions. You take lisinopril 10 milligrams once a day with every other day adherence. Your reading was elevated at 142/95 on a given date that you took your blood pressure at home. I'd like to take it today. Hopefully I did that. You're concerned is you forget to take it every other day. So adherence is an issue. That needs to be in my plan. For my adherence assessment, I'm talking about lifestyle modifications and monitoring. And then my plan, and I'm abbreviating this for display purposes only. We talk about the lisinopril, We talk about his diet and his exercise here. Continue to take your blood pressure at home. I talked about a blood pressure journal and his goal. Oh, we're going to go to 120/80 today, apparently. This should have been 130 according to my last slide. My community resources. So Paths to Health New Mexico is one. Also community resources to fit his needs that I may have. Maybe there's a community center that has a free gym and he doesn't want to pay membership. Immunization needs, and then you can have these templated out as well. 65 and older, 50 and above, so that who's ever writing the assessment and plan doesn't need to do a lot of searching for the ACIP schedule for that age group. And this is a resource guide that we sent out through the College of Pharmacy, and it's available, and I can get that to you again. And through the New Mexico Pharmacist Association, we sent this out as well. And it's just some of the things we put together for the state. So for example, and it's a couple of pages. If your patient says, well, I can't afford my medication co-pays or something like that. These are just some resources. There's one on hearing aids. There's one on cell phones. So there's a little caption for each of the community resources the patient may benefit from. Charting is pretty easy to see in a community pharmacy because I don't have a lot of places to put it. And so I usually am doing old school charting paper documentation. The more you can template, the ease of implementation and the better. For every MTM consult, usually there's a dosage change, adherence measure. We talk about adverse events if that's a concern with each med, the outcome goals, non-pharmacologics, community resources, over-the-counter recommendations, and immunizations. The barriers, well, you guys know this already. There's not a lot of extra time or training. It's undefined roles. Do people benefit from this, you know, incentive-wise in the pharmacy? No, we don't see dollars in our pocket, especially if you work for a chain, but there's indirect benefit and patient gets benefit. And sometimes that's hard to show patients. These are just some things that support. So just some charts and then CDC evidence of impact. So just to show you pharmacists doing MTM, it's important. The CDC thinks so too. Economic impact and effectiveness impact. All right, so those were all the questions I had. Those were all the slides I had. If you have any questions.
Awesome. Thanks so much, Dr. Bachyrycz. So I know we're at the 1:59 mark, but I do want to give everybody a chance to ask questions if they have them. And so just so you know, Krista has gone ahead and posted the evaluation link in the chat in case anybody needs to go ahead and pop off and you still need to request your CEUs. But anyway, I want to go back. So if you have any questions for either of our presenters today, go ahead and put it in chat or feel free to unmute yourselves and you can ask directly. I do want to point a couple of things out. So we have Terry and Renee who both chimed in that the Health Information Exchange, formerly NMHIC, is now synchronous. And so if you need to reach them, you can reach out to Terry Stewart or Renee Sussman. And Renee put her email in the chat, rssussman@synchronous.org. And then I think we answered one of Wayne's questions going back to Dr. Buszkiewicz presentation, but he was also asking about patient confidentiality window drive up. Do you want to address that real quick?
I just wanted to see what Jazz.
Oh, yes. Okay. So as far as patient confidentiality for completing the MTM services, if I am doing either an in-person full medication review or a phone MTM, I'm lucky enough in my pharmacy to have an office, the office I'm currently sitting in. We can close the door, we can have the privacy. I'm aware not every pharmacy has the space for that. So you have to be really conscientious, and maybe we're taking the time to take the patient away from the pharmacy window, or maybe we have an alternative window specifically for counseling available in the community pharmacy, if that's available for you and your workflow. Because sometimes these MTMs, when done properly and done correctly, can take up to an hour or more. So you want to make sure that before you approach your patient for the MTM, that you do have the time and space to do so appropriately and correctly. And maybe that means we aren't doing in-person MTMs. Maybe it is something we're doing over the phone in the back of the pharmacy, just to really respect that privacy and the need, depending on your pharmacy layout and workflow.
And Dr. Bachyrycz, how about you?
Thank you.
Yeah, I completely agree. I don't usually do things through the drive-through unless I have to, but I would try to vet it to where the patient feels comfortable and confident with you.
Okay. And then we had a question that I think was posted during Dr. Bachyrycz's presentation, but again, you're both welcome to answer. I think this is where Terry and Renee's comments were coming from too, in terms of how do you manage coordination of medical records from different healthcare settings? So Dr. Bachyrycz, we'll start with you.
Okay. So I really have limited records. So anything I can get my hands on, and I try to have an organized fashion. And I know it's a little bit old school in chain pharmacy because I don't have the documentation and reporting system. So whether it's a paper file with, little tabs, that works good for me. If I have, like I said, a template out, I liked the Duran's. Looks like you have a checklist, or that seems to work well for you guys. So yeah, I don't really have a great way to manage that. So did you want to give your 2 cents, Tesia?
Yeah, I would agree. I think that we didn't have quite enough time to talk about this sort of barrier during the presentation today. The big barrier between there not being a universal health record. I'm not able to see the patient's labs that they're getting done with the provider, and it can be very useful to MTM recommendations, such as a fibrate recommendation with a statin therapy. I really would benefit from being able to see the patient's labs before I call the provider's office, and I'm in a situation similar to Amy where I'm calling and making a recommendation that actually isn't appropriate, but I simply don't have all the information in front of me. So that is really, really tough. I can try to call the provider's offices and get the labs or the information, but one thing I've noticed is that you can never talk to a provider directly. I'm always speaking to someone at a desk or perhaps at a non-centralized refill service, and they do send a message to the provider, but frequently I don't get that response communicated to the pharmacy. Sometimes I'll call again and there is a response in the patient's profile, but it hasn't been shared with me. So I'll acknowledge that that is a big barrier because there's not really a coordination of medical records from these various healthcare settings. And moving forward, I would love to find a way to more closely work with providers' offices, to have better communication between community pharmacy staff and providers directly. I think it's something that I've noticed when I was a student, and now my first year of pharmacy, I'm just really kicking myself and wishing we all had a universal health record, because it would be so beneficial to providers, patients, and pharmacists involved in that care.
Great, thank you. And I think one more question before we end today's session. We have, please describe primary reimbursement concerns you or your techs deal with in your settings. So Dr. Buszkiewicz, let's start with you.
So really, if we're referring to those reimbursements from the star rating platforms, these reimbursements are tiny, you guys. I'm talking $5, $10 for an intervention with a patient that I may spend 15 to 30 minutes on. So I know that the reimbursement I'm getting from the star rating platforms is neither equivalent to my time or the tech's time spending on these sort of actions. They have slightly increased that reimbursement rate this last month for certain things, but it's really not enough that we're getting from the star ratings platform. So it's going to be finding additional funding in your pharmacy, finding different positions to allow for this and to provide that funding.
I would agree. And that's why I was talking about doing as much templated work as you possibly can. Because of the low reimbursements, we're not given more hours, more staffing, more training, more time. And if you can't fit it into workflow, It's very difficult. And so this isn't going to pay for a pharmacist.
Oh, dear.
So yeah, it's going to be important to try to do as much of the pre-work and have it templated out and have consistency, and then individualize that action plan and just do you remember Mad Libs? Kind of like that, and individualize as best you can with the time given. I know it sounds strange, but that's what we're up against with those low reimbursements.
Great. Thank you so much for your presentations and for your thoughts and responses to the questions. So as mentioned, we do have our session evaluation, and Chris has put the link in the chat, and then there's also the QR code on the screen that you can scan. This will take you to a Google form, and the evaluation will help us with our QI efforts and also allows you to request your CEUs. If you have any questions or issues in completing the evaluation, please feel free to email us at info@constellationnm.com. And again, if you have called in or are unable to follow the link or the QR code, please stay on the line and we will help you shortly. Thank you again to everyone for your attendance and participation today. Our next PHC meeting is coming up in January, and be on the lookout for the announcement coming from Krista this time instead of me. Special thanks to our presenters, Dr. Buszkiewicz and Dr. Bachyrycz. Have a great day, everyone, and we look forward to seeing you at our next PHC meeting in January.